The next topic to understand is congestive heart failure, or CHF. This is an extremely high-yield topic, not just for the exam, but also for clinical practice, so it's important to understand it thoroughly. A complete discussion of heart failure is beyond the scope of this lecture, but we'll review some of the important points here. First, a definition. CHF is a syndrome of poor ventricular function that is characterized by certain symptoms and signs. Before we get into treatment, it's useful to think about heart failure as either right-sided or left-sided, and sometimes both. This will help keep the symptoms straight. In right-sided heart failure, the right ventricle cannot pump adequately, leading to fluid and pressure backup into the venous system. This leads to hepatomegaly, jugular venous distension, and peripheral edema. On the other hand, left-sided heart failure causes fluid to back up from the left ventricle into the lungs, leading to pulmonary edema. When severe, it can also lead to orthopnea, which is defined as shortness of breath when supine. These lung systems are why the condition is called congestive heart failure, which can be seen on the following X-ray. The haziness over the lung fields in this X-ray is a result of pulmonary edema resulting from heart failure. It's important to remember that left heart failure and right heart failure can exist simultaneously. In fact, the most common cause of right heart failure is previous left heart failure, because over time pulmonary edema increases the workload on the right ventricle. In treating heart failure, many drugs can have a benefit, but the goals of therapy can be different. Some drugs, like ACE inhibitors, beta blockers, angiotensin receptor blockers, and spironolactone, have been shown to actually reduce mortality. On the other hand, diuretics like thiazide diuretics or loop diuretics, as well as nitrates, are used only for symptomatic relief and do not improve mortality. Next, let's move on to discuss bacterial endocarditis, which is an infection of the heart valves by various bacteria. Although this can happen in the context of normal valves, it is much more common in patients who have congenitally abnormal valves or who have had prior injury to their heart valves, such as with valve surgery. The mitral valve is the most commonly involved valve, but involvement of the tricuspid should tip you off to IV drug abuse, because contaminated drugs are injected directly into the vein, and this is a perfect source of bacteria flowing directly toward the tricuspid valve. The signs and symptoms of bacterial endocarditis include fever, raw spots on the retina, which are shown here, Osler's nodes on the fingers and toes, which are shown here, Janeway lesions on the palms and soles, a new murmur, and splinter hemorrhages under the fingernails, also known as nail bed hemorrhages. These all basically result from septic microemboli being shot off of the valves and disseminating to tissues throughout the body. If bacterial endocarditis happens acutely, the offending pathogen is often Staph aureus and may involve previously normal valves. On the other hand, if the disease develops subacutely, it is usually a less virulent organism, like Viridans streptococci, and it requires abnormal or previously diseased valves. While we're on the topic of endocarditis, it's worth taking a quick detour to talk about rheumatic fever. This condition can result after streptococcal pharyngitis, commonly known as strep throat. If it's not treated, in the long run, this can lead to heart valve damage and subsequent endocarditis. Of all the valves affected, the mitral valve is the most common. Interestingly, this is mostly an immune-mediated disease, and it's not a direct result of the bacteria. The mnemonic fevers can help you remember some important symptoms and findings of rheumatic fever. Another infection that can affect the heart is pericarditis, where the infection is not inside the heart but outside. Specifically, the pericardium is inflamed, and this causes sharp pain that improves with sitting up and leaning forward. Also, a pericardial friction rub may be heard. Of the three types listed here, only one is truly infectious, meaning that it's caused by pathogens. The other two are immunologic pericarditis, either in the case of Dressler syndrome, post-MI, or with systemic inflammatory diseases, like lupus. In the CT image shown here, one can see a thickened pericardium with increased enhancement, likely suggestive of pericarditis. Another very serious condition that can affect the pericardium is cardiac tamponade, also known as pericardial tamponade. This happens when some fluid, either blood or pleural effusions of some kind, accumulate inside the pericardium. After enough fluid builds up, the fluid begins to exert pressure on the ventricles and prevents them from contracting effectively, leading to a decrease in cardiac output. In severe cases, diastolic pressure will be equal in all four chambers of the heart because it will be primarily determined by the pericardial fluid rather than the mechanics of the heart. Clinically, a patient with cardiac tamponade will present with hypotension and jugular venous distension, or JVD, due to a failing heart, as well as distant heart sounds due to the fluid between the chest wall and the heart. Another important and very high-yield clinical finding in cardiac tamponade is pulsus paradoxus, which is characterized by a decrease in systolic pressure that corresponds with inspiration. This happens because inspiration lowers the intrathoracic pressure, which makes it even harder for the heart to eject blood during inspiration. Don't forget, though, that this can also be seen in other conditions, which are listed here. Before moving on to cardiac tumors and vascular diseases, let's take a minute to quickly discuss syphilitic heart disease. In modern clinical practice in the United States, tertiary syphilis is exceedingly rare, so you aren't likely to encounter this ever in your practice. However, if you practice outside the United States, you might see a few cases, and regardless, it tends to be a high-yield fact on the exam for some reason. In tertiary syphilis, the small blood vessels that supply the aorta itself, known as the vasa vasorum, are disrupted. This leads to a dilation of the aorta and the aortic root with associated calcification. These changes are classically described as tree bark, and in the long run, this can lead to aortic valve incompetence and aortic aneurysm.